Hello, my name is Dana Coulthard, and I welcome you to our webinar today, Canadian Healthcare, Debunking the Myths. This is a presentation by Healthcare for All Minnesota. It's the third in our series of the U.S. healthcare system is broken, fix it with Medicare for All. And our agenda for today is similar to our other webinars, part 1 and part 2, where we have the Vice Chair of Healthcare for All Minnesota, Ann Jones, who will present some slides. Then we will move to watching the video, which is produced by Fix It Healthcare. Then there'll be some additional slides, a Q&A, and a call to action. During the Q&A, we ask that questions be submitted in the Q&A box that's at the bottom menu of your screen. You can actually put questions in at any time during the presentation, and we will address them during the Q&A section. So let me introduce Ann Jones. Get her back on video here. Hi, Ann.
Hey, hi.
If you want to go ahead with the presentation.
Okay, welcome everybody to our third in a series. My name is Ann Jones. I am a registered nurse, and I have spent 45, almost 50 years in patient care in Minnesota in a variety of settings, mostly in a large academic medical center, University of Minnesota, now Fairview. And I have had a strong interest in healthcare policy and health systems and how we pay for healthcare. So I'm taking that to the next level here in my post world of work years, working to fix how we pay for healthcare in Minnesota and ultimately in our country. As you can see on the in my list of the story of my work, I did also, in addition to civilian healthcare, spent 23 years in the Air Force Reserve as a flight nurse. So that's my little window into the military medical system and the VA health system, which I'll talk a little bit about later on in this presentation. I will start by saying that as an industry executive, Vice President for Communications for Cigna Health Insurance Corporation, Wendell Potter, developed and promoted a number of myths about other healthcare payment systems, including the Canadian system, that he is now helping to correct. Mr. Potter narrates this video that we're about to look at today and is working hard to educate the public towards passing a Medicare for All here in the US. You can read his story in Deadly Spin. I highly recommend it. Want to comment that we're Healthcare for All Minnesota and Physicians for a National Health Program Minnesota, working very closely together, along with the Minnesota Nurses Association and a number of other allied organizations working toward reform. Our challenge isn't to prove that we need a better system of paying for healthcare, but to build the political will for real change. This is a partial list of organizations in Minnesota and around the country who are concerned and working on this issue, particularly a couple of organizations who represent farmers in small towns and communities in Minnesota, Small Business Alliances, and the Twin Cities Metro IBA, very big concern for small business. Move to Amend, who works on money and politics, and some other interest groups, including the Labor Campaign for Single Payer and National Nurses United, which is the umbrella group for our Minnesota Nurses Association here in Minnesota. So a little recap of some things that I know if you've joined our other webinars, you will have heard me say some of this. If you're new to this, I'll just go through why it's important that we understand why we have to change. And among those reasons are that 1 in 4 people in the US didn't get the care they need due to cost. and 1 in 5 people can't afford to go to the dentist. We have a shocking number of preventable deaths related to inability to get health care. And this was before the pandemic hit and the financial crisis that accompanied this public health crisis. So if we do nothing, these problems will only persist and resurface once we maybe get on the other side of this viral pandemic. But millions of people in this country have commercial insurance policies that cost too much in premiums, co-pays, deductibles, and co-insurance to use. So effectively, they have catastrophic coverage only. And we are certainly learning in the context of the high unemployment related to this, COVID-19, that insurance tied to a job is unstable, insecure, costly, disruptive, and often leads to gaps in coverage, requiring massive taxpayer subsidies to work. Even before COVID-19 hit, 29 million of us were uninsured and 41 million were underinsured due to cost. So we like to try to emphasize that treating healthcare as a business serves corporate interests, but often not our people. On the subject of the COVID-19 pandemic, unemployment in the US is now approximately 54 million and rising. A little over half of those people had employment-based insurance. So those people are, of course, seriously at risk of losing that coverage. As I said, this model requires massive public subsidies for employers who offer that coverage, and an over-reliance on privately owned and operated system of delivering health care, which is a mix of public, private, not-for-profit, and investor-owned, means that we have a care delivery system that runs more like a factory than a human service. We've underinvested in public health for decades, and that affects our readiness to handle a public health crisis like COVID-19. And then the loss of income that the accompanying this problem just worsens the effect of a serious public health crisis. The longer this lasts, the greater the likelihood that many of these jobs will not return. And I don't know that that's something we've actually addressed and coped with at all yet. So by the numbers, we have a system that costs too much, does too little, and just leaves too many people out. Even before the COVID-19 pandemic hit, we were spending 1/6 of an $18 trillion economy on just the healthcare sector. Yet we had those high uninsured and underinsured rates. Total health spending in this country is $3.7 trillion per year, 11,559 per person. And health spending in Minnesota was $47.1 billion in 2016, predicted to double over the next 10 years if we do nothing. This graph shows that we're number one. We spend 2 to 3 times per person the amount as other developed countries, including, and we're going to examine the Canadian system today. We spend roughly twice as much as they spend in Canada per person. And so what do we get for all this spending? Well, not as much as you would think. We rank 37th overall in health outcomes against other countries around the world, according to the World Health Organization. And our health outcomes, which are population health measures such as life expectancy, infant mortality rates, rates of chronic conditions, do not measure up against other developed countries. We come in last or near last in access, efficiency, and equity of a system. And this graph just shows you, this is put together by our Centers for Medicare and Medicaid Studies here in the US. It's designed to show you, when you pull out the insurance piece, that the model that we think covers, or many people think covers most people in this country, actually really provides only about 1/3 of total health spending. Private insurance sector is becoming less and less important as a part of the overall. And as I said, it requires heavy taxpayer subsidies to work. In Minnesota, again, prior to the COVID-19 pandemic, you can see that just slightly over half of people in Minnesota were actually covered by an employment-based model. our system, either an employer with large and self-insured or smaller and provided individual policies. Often Minnesotans, workers have to pay a significant amount of that premium, and it really makes puts smaller employers and small business owners at a disadvantage for attracting and keeping employees. That's so the small business community is really with us in trying to fix this. I won't go through all of this, but it's just a list that shows you how complex and our multi-payer system is, which creates an enormous administrative burden for our system. So coverage in the US is really a patchwork, and it's costing us a fortune. So let's take a look at the video, which talks about the system in place for our neighbors to the north and how it's been misrepresented in the ongoing effort by those opposed to fixing how we pay for healthcare in the US.
The Canadian healthcare system is riddled with problems like lack of available resources and technology.
There are people who actually die while they're waiting to see the doctor.
Canada is absolutely not better than it is here.
People have an opinion of the Canadian system, partly because of the work that I did.
For 20 years, I was a senior executive at two of the country's biggest health insurance companies. This white binder was one of the tools I used to convince Americans that the last thing we would want in this country was a healthcare system like most of the European countries and Canada have.
Well, we don't want the socialized healthcare they have in Canada. We want American solutions.
This book contains page after page of talking points and misinformation. It was created for the sole purpose of misleading people.
Government runs healthcare in Canada. Care is delayed or denied. Some patients wait a year for vital surgeries, delays that can be deadly.
I really didn't know much of anything about the Canadian system other than the information and talking points I was fed by industry-funded think tanks and lobbying groups.
Canada is a country where a family can get a hip replacement for their dog in under a week, but a family member has to wait 2 to 3 years.
Since leaving my corporate job, I have been on a mission to try to make amends for the role that I played in perpetuating one of the world's most expensive and inequitable healthcare systems.
The practices of the insurance industry over the past several years have contributed directly to the growing number of Americans who are uninsured and to the even more rapidly growing number of people who are underinsured.
At long last, I learned the truth about the Canadian system, and I feel an obligation to tell that truth and debunk the myths that I helped create when I was an industry spokesman. Myth number 1, the Canadian system is a government takeover of health care. Everyone in the health insurance business knows that the phrase government takeover scares the heck out of a lot of folks.
And the American people don't want a government takeover of health care,
which will put the government between patients and their doctors.
This is a government takeover of health care.
That is not
pure,
ideological. It is actual
incredible.
fact.
The truth is that Canadians have much more freedom of choice than we do in the U.S. They have a Medicare card that lets them see any doctor in the country. And they don't have to deal with insurance companies to get the care they need because health care is financed primarily with public funds. Doctors run their own practices, and hospitals are privately operated in Canada. Instead of having to deal with multiple insurance companies, they simply bill the government for their services.
As a Canadian physician, I sort of laugh when I hear people talk about government telling me what to do or government-run healthcare. That's certainly not been my experience.
The government does not interfere in clinical decisions.
I have an enormous degree of clinical autonomy.
In fact, very early in the Canadian system, doctors established an agreement that doctors would be self-employed.
I'm in practice. I'm a small business person. They're not running my business for me. They don't come in and review me and tell me, you're not doing this right, you're not doing that right.
Canadian doctors make decisions based on their best clinical judgment, not what the government or an insurance company bureaucrat tells them to do. Myth number 2, people are dying in wait lines. One of the most frequently cited myths about the Canadian system is that Canadians are dying on wait list.
And if you wait too long in line that you happen to pass away, that just is part of the way the system works in Europe and in Canada.
That lie is fed over and over by industry lobbyists and PR people to the media, politicians, and the general public. Wait times in Canada are managed according to medical need. Longer wait times are associated with elective procedures that pose no long-term threat to a patient's health.
This myth about Canadians dying on waiting list is simply that. It's a myth.
On average, how many Canadian patients on a waiting list die each year? Do you know?
I don't, sir, but I know that there are 45,000 in America who die waiting because they don't have insurance at all.
If you need immediate cancer surgery, you will get it quickly.
The concept is that people should be seen in the order of need. As a family physician, if I see patients in my office who are waiting for, say, an appointment with a specialist and there's some change in their circumstance, that their situation has become more urgent or they're uncomfortable or worried in some way, then the system is set up for me to be able to advocate to get them seen more quickly.
In the U.S., if you're uninsured, you might not get any care or be on any wait list because you don't have enough money. I can't tell you how many times people have told me they were counting the days until they became eligible for Medicare. That doesn't happen in Canada. Everyone gets care. And doctors, not the government, calls the shots as to when the care will be delivered.
My wife, for example, went through breast cancer a couple of years ago. You wouldn't believe how quickly she got in for the initial scans, for the initial biopsies, for surgery, for chemo, for radiation. We didn't wait, and moreover, we didn't pay a cent for it. So there was no financial burden, and the quality of care that we got in our public system was as high as in any elite private hospital you can imagine anywhere in the world.
Myth number 3, the quality of care in Canada is poor. The myth of poor quality in Canada is a well-embedded lie in the American perception of Canada.
Let's try nationalized health care. Never mind that in Canada, people actually come to the United States and pay extra so they can get the care they want.
My former colleagues and I led Americans to believe that Canadians come to America in droves to get the quality care they can't get in Canada.
Canadians, when they need a big operation, when something happens, they come into the United States in many cases.
So what's the truth? There's no evidence at all to indicate a significant number of Canadians come to the U.S. for care. In a survey of 18,000 Canadians, only 90 had received medical care in the U.S. in the previous year. Only 20 of those had come to the U.S. expressly for care. The others were emergency situations. In terms of quality, Canada surpasses the U.S. in leading indicators such as preventable deaths and infant mortality. Breast cancer survival rates in Canada and the U.S. are virtually identical. Before Canada adopted its Medicare system, life expectancy there was roughly the same as in the U.S. Since then, life expectancy in Canada is 82 versus 79 in the United States. By a whole host of measures, Canada has equal or better quality metrics compared to the U.S.
The strength of public support for our publicly funded health system is incredible, and it comes out in many surprising ways.
Well, it started with a question: who is the greatest Canadian?
A few years back, Canadians were asked by the Canadian Broadcast Corporation, who is the greatest Canadian in history? Who do they most admire in the whole long history of Canadian heroes?
And I have the envelope here. The greatest Canadian, as decided by you, is
Tommy!
Canadians chose Tommy Douglas, the father of the Canadian healthcare system.
Put health services for every man, woman, and child, irrespective of their income, their age, or their physical condition.
The truth is that the vast majority of Canadians are very proud of their system.
The core value of maintaining healthcare as a universally accessible, publicly funded right of citizenship, that core value is virtually universal. There isn't a politician in Canada that would dare propose to do away with that fundamental nature of our system, because they wouldn't stand a chance. That's how solid the support is among Canadians for publicly funded healthcare.
Okay, now Anne's going to continue with her slides.
Bear with me for a minute while I get back to my starting point following the video. Thank you so much for your patience. So the birth of Medicare in Canada. Medicare in Canada started in the province of Saskatchewan on July 1st, 1962. You've probably all heard a little bit about this story. But I found it just fascinating to dig a little deeper. It would become the first government-controlled universal comprehensive single-payer medical insurance plan in North America. The medical establishment and the insurance industry vehemently opposed, fearing that it would become popular and spread, which it did. Within 10 years, all of Canada was covered by a medical insurance system based on the Saskatchewan plan, and no serious politician would openly oppose it. But it didn't come easy. Minnesota could be Saskatchewan, but first we would have to overcome a well-funded, well-organized, ideologically bound opposition, the medical industrial complex. The breakthrough in Saskatchewan grew out of the cooperative movement known as agrarian socialism, intended to influence an entire economy, but which moved eventually towards social democratic structures. You'll remember that Senator Bernie Sanders, who popularized Medicare for All in his 2016 campaign for president, often described our system as a social democracy with public services that are publicly funded that benefit all of us. The fight to pass Medicare in Saskatchewan has fascinating parallels to the fight for Medicare in the US and the fight for Medicare for all. This is just to expand a little bit on the concept of a social democracy. I would argue that we have already decided that it works well to do a lot of things together as a society. None of us could afford to pay for all of these services separately, and we count on them to be there. We fund them with our system of taxation. And if we looked at healthcare in the same way as public schools, infrastructure, and so on, and the common defense, we could easily design a payment system that would fund healthcare delivery in a way that actually meets the needs of individuals, families, and businesses. So going back to the Canadian system, Medicare in Canada was not without a fight. Universal state medical insurance was a major issue in Saskatchewan in the provincial election of 1960. And they have a party named the CCF, or the Cooperative Commonwealth Federation. It was the majority party at the time. The Canadian Medical Association, other medical associations, the local media, and even our own American Medical Association openly and vehemently opposed what they called socialized medicine, organizing a campaign against this proposal and using tactics similar to those in the US. Is this sounding familiar? They printed propaganda, they advertised, flooded the radio and newspapers at the time. Physicians and prominent figures held public meetings, often backed by the local Chamber of Commerce and boards of trade. The scare tactics included denunciations of socialism, communism, socialized medicine, the evils of compulsion, even threats of compulsory abortion, and state bureaucrats who would commit people to mental hospitals. I mean, they kind of pulled no punches. Claims that people would not be able to choose their own doctors, of course, featured prominently, and suggestions that doctors would leave and be replaced by inferior foreign practitioners. Well, the CCF won a majority of seats that year amongst 4 political parties in 1960. Anti-Medicare forces included businesses, political, and medical professionals. They even, as kind of a distraction, even proposed that government subsidize private health insurance instead, a little bit like our subsidized programs here, or even the push for a public option instead of a real fix. The one thing that was really sort of shocking and changed the game eventually was the doctor's strike for 23 days in 1962. As prospects for success grew, the opposition became even more extreme. Doctors in Saskatchewan went out on strike, and it's a story in itself. When I was reading about this, it said books have been written about this. A very divisive campaign to prevent reform took hold. And as an alternative, some of the physicians who were interested in reform started up with the government community clinics to serve the people. And it was sort of the threat of this government-owned system that actually brought physicians in Saskatchewan around to at least negotiating on this issue. So I'm giving you the short version because it's a rather long and interesting story. But this infamous doctor's strike, the bad faith of the opposition, and a strong coalition of pro-Medicare forces, which included the Farmers Union in Saskatchewan, the trade union movement, rank and file party activists, did eventually swing public opinion against, it was pretty obvious right-wing manipulation in that province in Canada. The strike was called off after some compromises, and primarily that medical insurance, as it ended up, would be government controlled, required, universal, and reasonably comprehensive. And that would form the basis of coverage going forward in the province of Saskatchewan. The Canadian Medical Association then tried to slow it down by asking for a commission to study the whole system of coverage across Canada. And this actually backfired because the commission wound up endorsing Medicare, the publicly funded system, in the face of strong public support across Canada and progressive political forces. You can read about the story in a publication called The Canadian Dimension. It's called The Birth of Medicare. So is the Canadian health system socialized medicine? I am not actually implying that this is a bad thing, but opponents of reform continue to use this as a pejorative, so we have to address it. I encourage that we think of public insurance as social insurance in the same way we provide social insurance for the elderly, the disabled, and the poor. We also need to remind the public that business and commercial interests in the US and in Canada as well enjoy enormous public subsidies, too numerous to list here. But the definition of classic socialism is an economic and political system based on public or collective ownership of the means of production. Systems vary widely around the world. The only developed country that has what we would call a socialized, it's called socialized medicine, is Great Britain, the National Health System, or the NHS, which is actually a source of great national pride in the UK and gets high marks from the Commonwealth Fund for quality, access, efficiency, and equity. The Canadian healthcare system is publicly funded and administered by the provinces and territories, with private insurance available in addition. Most hospitals are owned and operated by nonprofit voluntary organizations, and physicians, as you learned in the video, can choose private practice. And contrary to the fear that physicians would flee Canada to practice elsewhere, we actually have American physicians going up to Canada to practice. The woman in the who you saw taking a blood pressure in her office, it actually is from the US originally. We already have socialized healthcare systems in the US. So misuse of this term to mean a political system really doesn't serve us. Social means society or means people. Social insurance, publicly funded, is a public good. Our Veterans Health Administration is socialized medicine. And military medicine is government run with the use of some civilian contracted services near US bases, but entirely Department of Defense if you are deployed to a combat zone. The federal government owns VA facilities. The employees are federal government employees. The Secretary of Veterans Affairs, however, is a political appointee. Military medicine and the VA system contribute significantly to medical research and graduate medical education. And contrary to what you would think by reading some headlines or listening to media coverage, the VA achieves as good or better health outcomes as our civilian system. So in Canada, what's covered and what isn't? There is some, it's important to recognize that their system isn't perfect, but it does provide a high degree of health security across a very large landmass at half the cost for a population that is 1/10 that of the US. I need to update this because their population is actually around 36 million and ours is a little under 330 million. Hospital and physician costs are covered for medically necessary care for all residents. Gaps in coverage include dental care. Drugs are paid for if you're in a hospital, but outpatient drugs are private purchase, and then long-term care is covered in a variety of ways. Some private pay, some subsidized. 2/3 of Canadians have private insurance for some of these costs. And although the government does regulate prices, which makes it a lot easier to purchase things like prescription drugs on your own, they emphasize primary health services probably more strongly than we do, and the system is portable across provinces and territories. I would say distance and population are probably a factor in the availability of services and kind of contribute to what you hear about wait times, although most of that is anecdotal. Activists in Canada are pushing for improvements because they recognize that there are upgrades and changes that need to be made. The Minnesota Health Plan and our Medicare for All Act of 2019 are both actually more comprehensive than the Canada Health Act. So I think it's important to emphasize that we're going to be creating an American system. We're not necessarily going to be copying something else, and try to take the best of what's out there. On that subject of that Wendell Potter addressed about this flood of people who supposedly come across state lines to get care in our great system, you can see by this slide that a tiny little sliver of people actually use the healthcare system, and often it's because they're traveling here and they have to use emergency care for some reason. If there is something that is extremely complex that we have the ability to offer a Canadian, their system then pays to send people here, but it's very limited. And of course, right now, very little medical tourism is happening. Americans are far more likely to seek affordable care outside the US than others are to come here. We have a phenomenon of medical tourism outside our borders. It's currently officially illegal to import drugs for personal use, but people do it all the time when they're trying to save money, and this is actually potentially hazardous. We need to deal with the cost of drugs here at home. By the numbers, somewhere between 850,000 and 1.2 million people traveled outside the US in an article I looked at in 2013 to seek care at lower cost. And this trend is actually growing until it was disrupted by the pandemic, of course. Thousands of people were crossing into Mexico every day for dental care. You could even book your appointments online. And we have people crossing into Canada from Minnesota, as you know, to buy insulin at 1/10 the cost of prices in the US. Now, the Insulin Affordability Act that was just passed in April here in Minnesota is supposed to be addressing this, but it may be held up in the courts now. These are just a few examples. And I will just note that I really do not endorse taking resources, either supplies or people, from other countries to solve our healthcare system deficiencies. And this whole phenomenon of medical tourism is experiencing significant disruption due to COVID-19. What about public support by Canadians for their system? Their National Medical and Care Insurance Act passed in 1966, which spread the system across all the provinces and territories. And it passed by an overwhelming vote. It started in July of 1968. Public support for Medicare, Canadian Medicare, remains strong in Canada, but their system does experience challenges from forces wanting to privatize. Some concerns exist that a shifting political culture would pose a threat, although you heard a strong endorsement from speakers in the video. My sense of the difference between Canada and the US is that Canadians experience a level of social cohesion that we seem to lack, and that I fear is getting a little worse right now. They want their fellow Canadians to be cared for and are willing to pay a little more in taxes if that's needed. And actually, we pay a lot of taxes here in the US and often don't get a good value for that. So I'll stop here and take some questions.
Hello, I'm actually going to add one of our participants agreed to help answer questions as she lived in Canada for a number of years. Her name is Claire O'Connor. And I'm going to get her set up here. Just takes me a minute. See if Claire can get her video and audio going. Let's see. So, not sure where you look, Claire. Let's see, unmute. Hi, Claire, I think I've got your audio on.
Actually, I've been on all along, but when you switched, yeah, I got kicked off. Oh, there I am. Can you hear me?
Yes, we can hear you.
My audio's on, but my camera's not on.
Would you like to put your camera on or leave it just with the audio?
It doesn't matter to me. And I'll be happy to answer any questions.
Okay, so I selected ask to start your video, so.
Yeah, go ahead. Oh, there I am. Yeah.
All right. Hi, Claire.
Hello.
Just to introduce myself, I'm actually grew up in St. Paul, but when my new husband got a job in Regina, Saskatchewan, we went there and it was a one-year position and we stayed for 26 years. And partly because I love the healthcare system, but no, obviously a lot of reasons for that. But I just thought, I don't think you knew when I volunteered to come on today that I lived in Saskatchewan.
No, I didn't know that.
Except
I remember you though from joining us at our South Minneapolis group meeting. So
yeah.
Welcome, great to see you.
And here is, I looked for it this morning, and here is my health card. This is how they handled socialized medicine in Canada. Looks like a credit card, doesn't it?
Mm-hmm.
Yeah. You just present this and you get everything you want. My husband and I, we didn't know, and we were just going there for a year. So there was, when we crossed the border, there was some test. I think it was, a TB or something that we didn't have. So we had to promise to go to the doctor the next morning. So we did that. We walked in, we got our test, everything was just fine. And as we were leaving, my husband pulled out his wallet, put some cash out there, and the woman looked at us absolutely dumbfounded, just absolutely. And she said, "I don't know what to do with that."
Awesome.
I said, "We don't charge." So it was such a new concept that we were just, and us giggling as we left them. Oh my gosh, that was free. Oh my gosh, it was free. Yeah. So I thank you for the history. I just wanted to add a little bit to the history, and that is, now when we went there, the healthcare system was already in. It had been in for 10 years. But the two things that I'd like to add to your history is that the same social movement that created the CCF and then the healthcare system was the same movement that created our our Farmer Labor Party. So we had the same movement in Minnesota to have carried us through to that, but for whatever reason, and I don't know the reasons, we didn't. And then the Democratic Party took over our Farmer Labor Party. The other thing is, and you did touch on this, and you touched on the fact that it was, it was a long slog. It was a lot of work. But as I listened to people and got to know people there, I heard more and more about how really tough it was for them and how they had to work really hard, a lot of persistence, a lot of attacks, and they weathered it and got the universal healthcare system, elected Tommy Douglas. And the other thing to say is that it always was intended to cover dental and pharmacy, but they never did get there. So, and they're still working for that. They're still trying for that. So there have been over the years many internal attacks. Stephen Harper, when he was elected prime minister, he kept trying to get rid of the healthcare system, and everybody in Canada absolutely rose up and would not have it. Everywhere in Canada, not just Saskatchewan. And so finally, Stephen Harper was defeated, and primarily it was because of his attack on healthcare. So that kind of is, is kind of giving them a resume that we can pay attention to, how important, and once you get it, how loyal people are to it. So.
Right. And I think we're seeing a little bit of that here in the US with the increased support for the ACA, for the Affordable Care Act. People are initially resistant. They maybe don't fully understand it, what it's giving them. But over time, we've seen increased support for that as well. So, so there's a pattern there.
I do have to caution, it also is a really watered down version that the healthcare industry is a little bit more tolerant of, because it doesn't cut into their profit as much.
That's right.
So, so we do have to be aware of being offered something that's a kind of a halfway, that won't take as much profit from the healthcare. You can see I'm really strong about this issue.
Exactly right. You're
Yep.
Anybody doubt?
Singing our tune, Claire.
Anyway, there's a lot of questions there, so I will pick up.
All right. So the first question we have is, have they had a problem with underfunding? Do either of you know anything about that?
When I read, and I can't say that I've studied it closely enough. It's chronically a concern, because they're needing to cover such a vast landmass with a relatively small population, 36 million as opposed to our 330 million. So yes, there are constantly concerns about facilities and staffing, and but the political will to preserve and improve the system is really overcome much of that. If you remember the Fix It video that the very first one, Healthcare at the Tipping Point, showed that taxes in Canada and the US are about the same. A woman who prepares taxes across the border says it's about the same. It's just that they get way more social services than we get here in the US. And we overspend on probably the military, among other things. But
great, thank you, Anne. There's a question about long-term care coverage. Is that covered in Canada? Do we know?
Very good question. And Claire, you might be able to give some insight. I pulled off a really long piece about long-term care coverage, and I didn't have time to study it carefully. But as I understand it, it's a mix of private pay and subsidized coverage and coverage for at-home care, support at home. Any comments, Claire? It is a gap, though.
Actually, there has been a bit of a brouhaha about it in Toronto during the height of their, new introduction to COVID. And like everybody else, they couldn't manage the healthcare, so they brought in the army. I think that's quite Canadian.
Yeah.
In the U.S., we bring in the army to put people in jail. So. But they brought in the U.S., they brought in the Army, and the Army reported on the abuses that they saw. And yeah, right. And they found out that there were a lot of abuses, a lot of neglect, and a lot of unexplained deaths. And that was in the extended care facilities. And so that was made public a few months ago, and they are right now in the process of doing an investigation of that. So I think what we'll find out is it's a mixture of public and private, more private than we would expect in Canada. And I think that they're gonna come to a question about whether or not that's an appropriate way to care for people.
So, and I'll point out that 1384, HR 1384, and proposes to create a system that is birth to death. I mean, we would consider long-term care as just part of our healthcare system. So that is currently Medicaid covers a lot of long-term care in this country after private resources are exhausted, and that is really fairly inequitable. And of course, and nursing homes are heavily regulated in the U.S. as well. But we could smooth that out by just calling all medically necessary ages, just an increased level of disability or inability to care for yourself, and it would be covered in 1384. So that's
at the risk of running my mouth too much and somebody saying shut up, actually, there is an incredible difference between the quality, and this is measured by outcomes and comparing the two systems, the quality in Minnesota between the extended care facilities that are nonprofit and the ones that are for-profit. And the answer to that is pretty obvious. The for-profit facilities are rated much lower on every level, and the not-for-profit are rated higher, and the results are better.
Yeah, thank you.
Okay. Let's see. We have a question about how the Medicare for All bill addresses the Medicare Advantage plans, how that works in the bill.
Medicare Advantage would no longer be needed at all. And actually, the bill specifically prohibits commercial insurance for coverage that are provided in Medicare for All 1384. So you don't need a supplemental insurance plan, and you wouldn't be allowed, which is of course one of the complaints on the right. You can't prohibit health insurance when you don't need it. So all the gaps in coverage that Medicare Advantage is designed to pay for are covered under medically necessary care in our Medicare for All proposals, both of them. So it's an interesting question, it's just not needed. And little known fact, Medicare Advantage gets between you and Medicare, and people find out that they are now being managed as though they have commercial insurance, and can run up against denials and problems with pre-authorization. So we eliminate all of that with a Medicare for All in the U.S.
And can you expand on what exactly Medicare Advantage plans are and why they're kind of a problem?
Well, as I commented, they're advertised to cover things like vision, hearing, dental care, which is not covered actually in any health insurance plan right now, and offer this. There are a few other little perks thrown in, and offer to cover what Medicare doesn't pay. So heavily advertised, as you know. But again, the need for that would be eliminated, and they become your managed care policy, which means that they're actually overcharging Medicare in many cases for coverage, including prescription coverage. So for a lot of reasons,
don't they tend to drop sick people?
They can, yes, they can drop you if you become too expensive, and then you might have trouble getting back on Medicare, which is really confounding to me. So
they're really not adding to the availability of healthcare. It's just more of a profit-making enterprise for those health insurance companies. A couple of questions on the current status of the Minnesota Health Plan and the Medicare for All Act.
I've got a slide for that if you want to give me a chance after we finish with Q&A and the call to action, but in the call to action section. But we were, just short version, unable to get any hearings. Bills for on the House side and the Senate side have been reintroduced for a Minnesota health plan. If we are unable to get a national health plan in place, and no hearings have been held, primarily because the legislature has been split between political parties, and I guess the Democrats decided not to hold hearings if you can't hold any hearings in the Senate. You know, the House decided not to hold hearings because there would be no comparable hearings in the Senate. So, election 2020, I'm going to make a pitch for.
Great, thanks.
If I can add also that the Democratic Party just recently refused to put universal health coverage on their platform, which I am furious about.
Right, that would be at the national.
Yeah, that's a national level.
DNC platform. Yes, we have had a lot of conversation about that, and we're going to talk about it in our upcoming quarterly meeting too. Yeah. It means the public's got to push. That just brings it right back to, it puts it right back in our court to push.
It does, and it really is evidence of the fact that we have to fight. We have to fight for this, just like Canada had to fight for this. And there is, of course, a lot of pushback. The medical industrial complex, who's making so much money, certainly doesn't want to give that up. And that's where the clash happens. But we as the public have to organize and use our power to elect the right people into office, and to push for the real change that we need.
Exactly.
We have a question for Claire. Can you please speak to the Canadian Medicare system for seniors? I was told it lacks coverage for seniors.
It's limited coverage, and I have to say that I was completely unaware. I went up there when I was 22 years old, and then left in 1997. So, I just never thought about that demographic at all. This latest stuff that was found in Ontario, I was completely unaware of it. I do know that there were a lot of, in Saskatchewan, there were a lot of what people often went to were the homes. People would welcome seniors into their homes and give them care, and that was supported by the healthcare system. They were paid for that, but that would have been a very low investment and also not a lot of service. So I have to say, I don't know what it was in Saskatchewan, what the coverage was, and I have to say, I'm really sorry. And
well, I think
what I have to say is I will find out. I'll contact some people and find out.
So just to be clear, what you're talking about is long-term care or kind of custodial care. But hospital care, surgery, preventive care, and so on is all the same. I mean, that's covered. That would be considered for all ages. It's really maybe long-term and disability care that's
Yeah, thank you for that. Yes, yes,
yeah.
indeed. It's care there is from birth to death. Healthcare, all the healthcare needs. It's the long-term care. Yeah.
How did do we have any more details about how Canadians fought back against health insurance companies back in 1962 and what we might learn from their fight?
What I know mostly, actually, my daughter-in-law's father was very active in that, and I could ask her what the inside fight. I went there when the fight was over, but I do know that electing Tommy Douglas, and I'm so glad to hear Tommy Douglas is a favorite person in Canada, but electing him to office to be the Premier of Saskatchewan, that's where he started. Then he went to be be an MP. That's federal office. And so I think that a lot of what they did was focus on the election. And so that was the way that they battled, because they knew that he was a champion from the day he entered politics. That's what he was all about. And so I think that that's the choice they made. But the Saskatchewan is a very rural country, province. And so there had to have been lots of small town activists. And I will check with my daughter-in-law, she knows.
Just the article that I relied on most heavily to explain the fight for Medicare for all, it was in a publication called Canadian Dimension, and I think it was written in about 2012. And they described a really bitter fight to get this in place, and with a coalition of groups made up of the Saskatchewan Farmers Union, trade unionists, and other progressive groups, and they had to battle some pretty well-funded. It's really, the parallels are just remarkable.
Yes, yes. Well, really the battle for Medicare here and Medicaid here, I think was very similar too. Like this stuff did not come easy. Any program or right we have was a huge fight. Women's right to vote, civil rights, the Voting Rights Act, fair housing, Medicare, Medicaid, Social Security, all of that stuff was hard fought.
The only possible thing we might have on our side this time around is that it's really becoming clear that employment-based insurance is not secure or stable. And I hope we can make that argument a little more strongly. We're hampered a little bit by not being able to do the in-person work that we would like to do. So thank you all for joining us on our virtual meetings and webinars.
And speaking of, someone was curious how many people are joining in. At one point we had 77 people.
Oh, good.
So we've got a good turnout. I will just ask you to reiterate about how hospitals are owned in Canada. My understanding is they are private, but are they private or are they public hospitals?
They're private, funded publicly. So they're internally managed, but of course there are all kinds of healthcare standards like there are here. Doctors are tested, and and they're constantly monitoring them. Saskatchewan, the monitoring is very, very intensive. They're very careful about their quality of care. They, after all, are Saskatchewan people. They want they want to know that they have the best. The other thing I wanted to say, and I'll shut up after this, is that we get the argument, but we can't afford it. And it took me quite a while of hearing that, thinking, what's wrong with that response? And we just heard it recently from one of our candidates for president. We can't afford it. How are we going to afford it? Well, number one, there's an obvious answer to that. We stopped spending money on the military. I mean, that's clear. It's clear. What we need for healthcare, they pay for one bomber. The other is you're changing the subject. That's not the subject. The subject is we need health care. We'll deal with that once we've decided, yes, indeed, healthcare is what we need. And it's an argument that's used all the time, and it's like this double twist that we get so used to. It's not the issue. Let's move on. Let's talk about what is the focus. I mean, you can say the same thing about the military and about, about schools, about policing, about everything. So I'll unmute here because I seem to have something going on in the.
What was that? So the answer to that also is there's plenty of money already in the system. We are really just talking about redirecting and reducing a lot of administrative waste and then going after prices. So that the money thing just becomes a scare tactic that if, so we're trying hard to make sure that we make the economic case as well so that people feel confident that they can make that case. And we'll keep working on that.
All right, well, in the interest of time, I know there's several questions we haven't gotten to, but we've pledged to try to keep these webinars on the shorter side, but we always go longer because there's so much to say, but I think we're gonna have to move on. Thank you so much, Claire, for joining in. You were a very valuable addition. Thank you.
Well, I have some homework to do, so I'll do that.
Thank you. This is not, we can revisit this topic too, and we will.
I have a siren going off.
It's Wednesday at noon.
Yeah, so I apologize for that.
Me too.
I did mute myself earlier. Hopefully it's not too bad. But anyways, Anne, please go ahead with the rest of your slides.
Hey, since we talked about activism, and let me just talk about what you can do to help, and the fact that it is going to take all of us. We, Healthcare for All Minnesota, and some of our partner organizations really exist primarily to create demand for change and bring people to the fight. We need to create more of us. If you take a look at some of the activism over this, spring and summer, you can see how much pressure it takes to bring issues to the fore and really make office holders feel the pressure to change. I mean, the same fight goes on with climate change and the environment, gun violence prevention, and now criminal justice reform. My argument for working on healthcare and health policy is that if we could get this one off the table, we'd have a lot of energy and resources to start fixing some other things that really need fixing. But anyway, we want to bring more people to the fight, engage, educate, and build our base of support. So we ask you, if you are not already on our mailing list and you're listening today, please just go to Healthcare for All Minnesota, healthcareforallmn.org. Very easy. Right on the front page, you'll see join us, and you can just put your contact information. We would love to have your contact information, and we are very respectful of your inbox, but please take a look at what we send out, because it will usually be either an educational opportunity or a call to action. When we were able to do, and when we are able to do in-person events, we try to get out and talk to members of the public. We organize actions to promote change. We're working hard to link effectively with other organizations on this issue. And what we really need to do is hold candidates accountable for reform that's on each of us, and create the political will that we need to pass and implement legislation. Part of what we do too is become more educated so that we are each honest brokers for this issue and can offer information to candidates and office holders. So learning more about it, knowledge is really power and key to your feeling like you are able to talk about this with confidence and be effective. So I've listed a bunch of websites and information places you can go for more information. I would also encourage just repeating some of the stuff we've done over the last few weeks and months, because you'd be surprised how much you learn when you relook at something. I especially suggest reading Senator Marty's book called Healing Healthcare, The Case for a Common Sense Universal Healthcare System. He does a really good job of discussing policy, the specific proposal for here in Minnesota, and a transition plan for getting there. And then websites, the PNHP website, Physicians for a National Health Program, is just an incredible source for information. And then you can see our website as well. And again, please sign up if you haven't joined us already. Then other organizations involved in this Medicare for All fight here in the US, I listed, and then here's some the websites for these groups. I will just say that I talked about the social cohesion that I believe exists maybe in the Canadian society more so than ours, but that we do need to reinforce and maybe rebuild going forward, understanding that we are all in this together. Something that you can do right now when you leave this webinar, and if you want to take your phone and do a screenshot of this information, we are asking or suggesting that people call their members of Congress, because 2 bills have been proposed that would help alleviate some of the immediate concerns about people being able to get health care in this economic crisis caused by a public health crisis. So please call about your representatives and your senators about the Medicare Crisis Program, which would expand Medicare Parts A and B to any resident eligible for unemployment insurance. That would help everybody who's lost their coverage because they've lost their employment-based insurance. And then the Healthcare Emergency Guarantee Act for anyone who's currently uninsured and covers out-of-pocket costs for those with insurance. So thank you for that. And then I mentioned that I had a slide of the dual track toward a national health plan, the bills that have been introduced in the House and Senate and at the state legislature, and then the bills that have been introduced at the federal level. There were a few hearings in the House of Representatives over this last year for HR 1384. Those bills would have to be reconciled, and the HR 1384 is more similar to our Minnesota Health Plan proposal. And then election 2020, fixing this will take legislation. So I'll just do just a few quick facts about, or encourage you to be a healthcare voter. And you can go to mnvotes.org to confirm that you are registered to vote. We are encouraged to do this frequently for voting rights activists. That's a concern. I feel like we shouldn't have to worry about it in Minnesota, but it's always worth making sure that you're registered to vote. And if your address changed, make sure you're registered to vote at your current address. If not, you can register to vote online. Also to find polling places and early voting locations. Those may change or become less because of the inability to staff polling places. Primary election day is August 11th. Consider voting early in person. I think it might be a little late to mail in a ballot right now for the primary. Election day, November 3rd, 2020. And we do need a legislature and a Congress friendly to this issue. Healthcare for All Minnesota tries to be nonpartisan, at least officially nonpartisan. We kind of know who our friends are in these governing bodies, but the majority party sets the agenda. And as I've already said, they still need to be pushed. My contact information is on this slide. Feel free to contact me personally. And I will thank you for joining us today.
Thank you, Anne. I hope everyone found this to be helpful and informative. I did want to let you know that the webinar has been recorded and it will be available on our YouTube channel. And I will also send out a link to it in a post-webinar email. If you would like to be informed of future webinars and educational offerings, please join our email list. You will be directed there after the webinar. Let's see, was there another thing?
Our quarterly meeting coming up on August 29th.
So our organization has quarterly meetings, and our next one is Saturday, August 29th. again, you could get notified about the details of how to join that meeting. It will be online through our email list. We also advertise on our Facebook page, so please like our Facebook page also to stay updated. Thank you so much. Anything else, Ann?
Well, I'll make another pitch to create more of us. So whenever you get an invitation to join an event, please share it. And it's worth kind of making a personal, contact with people to invite them to join. And, we all see a lot of stuff going across our computer screens, but sometimes when we call attention to something or encourage people to participate, they will. So it's going to take all of us to move this forward.
Absolutely. All right, well, that concludes our webinar for today. So please go ahead and exit and look for those emails, those follow-up emails that will be coming. Thank you again.